Hi everyone. This is just our little video I had promised you guys um, to make sure that I finished the lecture that we had started for Pharm. So yeah, I'm just gonna go ahead and go over everything that we've missed, plus kind of review what we've already talked about a little bit, so it could be more comprehensive and thorough. Um, so yeah, let's go to our cardio first. As we talked about our RAS system and why it gets started and how ACE and ARB inhibitors work. So as we talked about with ACE inhibitors, like our lisinoprils, our enalaprils, the uses are the hypertension, heart failure, the renal protective for diabetes. Remember we talked about how it affects the kidneys so much that they need a renoprotective medication. The metformin really works on those kidneys. An adverse effect we talked about, which is huge, the cough, the persistent cough, the dry cough, however you want to say it, but it's the cough, as well as hyperkalemia, hypotension, angioedema. If you see somebody with angioedema, you want to stop the drug um, and make sure that they're not having any kind of allergic reaction or um, airway problems. And then with ARBs, we start. Let me go back here real quick. And then with ARBs, we talked about the losartan has a sartan ending. Um, that's used for hypertension, heart failure, and diabetic kidney disease. So again, adverse effects include hyperkalemia, hypotension, the renal impairment. So you want to go ahead and make sure that we monitor the BP, the potassium, the renal function, and it is not to be given in pregnancy, as well as ACE and the ARBs both aren't supposed to be given in pregnancy. And then go ahead and make sure that you look at your antidotes and the mnemonics to kind of help you understand. And next we talked about beta blockers. Beta blockers are LOLs, and they work on the heart rate as well as the blood pressure. So you have propranolol, carvedilol, metoprolol, atenolol. Um, So you want to look out for any kind of bradycardia, hypotension, fatigue, bronchospasm. Remember we talked about it is not to be given with asthma and due to the bronchospasms. And it also masks hypoglycemia. So we want to look out for that. Check apical pulse, correct for that 1 minute, and hold with the parameters, and then let your doctor know if you see anything different, but do not stop abruptly. Use caution again with asthma and diabetes. Next, we have the calcium channel blockers, like our nifedipine and amlodipine. We talked about how nifedipine can be given in pregnancy under the guidance of the physician, and it blocks the calcium, so that's hence the vasodilation. So we want to go ahead and make sure we look out for the peripheral edema, headaches, flushing, reflex tachycardia, bradycardia. And if a question really asks you why do we need, what is the therapeutic, it's either it lowers the blood pressure or, depending on what the answers they give you, but it is, a blood pressure lowering medication. So sometimes it could be that simple in a question, so we want to make sure that we don't overcomplicate it in our thinking. So we want to go ahead and monitor that BP and pulse, hold for hypotension, bradycardia, and then avoid the grapefruit. Remember, grapefruit plus dipine is equal to danger. And then verapamil could be very constipating, and very slow heart cause that bradycardia. You want to make sure that you go ahead and teach your patients about that. And then we talked about for chest pain, our nitrates and vasodilators. So you have your nitroglycerin. It could be given sublingual, spray, patch, IV, but it's never given oral. Um, And then you have your isosorbide as well as hydralazine, which is a direct vasodilator. And we talked about with nitrates that patient can't get those headaches. So it is something that is expected. But now let's say that their headache is not stopping or their headache is, just so severe, then they should definitely call 911 or go to the nearest urgent care. So because of the vasodilation, that headache can come about. So indications include acute and chronic angina, heart failure, and then hypertensive emergency, the IV if needed for like hydralazine. So some people I've noticed, if they're not taking their medications or are out of compliance, they will go to the hospital and they will give IV hydralazine. That really help with that. And then we have, again, adverse effect, throbbing headache, as I talked about. It is something that can happen with nitrates, but again, if it's not going away, it's severe, they should let their doctor know. Hypotension, dizziness, reflex tachycardia, and then contraindications include erectile dysfunction with that sildenafil that we talked about. There's fatal hypotension, right, with the sildenafil. So you don't want to give nitrates and Viagra together. And then also sublingual, 1 tab, Q5 minutes times 3. You want to call 911 if no relief after the first. Um, so I think we said after the third, but it is actually the first time you need to go ahead and call the doctor and continue to take the medication. Store in a dark glass. Um, and then with the patch, you want to make sure that you're switching sides and it's removed every 10 to 12 hours to prevent tolerance. So you don't want it to be, that they get it, but now they're so tolerable to it that it doesn't even do anything. Um, and then again, with the sildenafil and nitrates, severe hypotension. And some of the interventions if somebody goes into hypotension that you could do right away without a doctor's order would be to put them in that Trendelenburg position and try to get that blood going up and moving towards the heart and the brain. So we want to make sure that we go ahead and do that and call the doctor if that's the case. But if it's so severe, again, you're going to need to call your rapid response teams. We've talked about digoxin, and digoxin to make sure that you know the antidote is digibind and when you would need to use that. Toxicity, you would see nausea, vomiting, the yellow and green halos, bradycardia, dysrhythmia, just a lot of confusion. Um, Hypokalemia is a contraindication, so potentiates the toxicity, so it like adds to um, the toxicity. So renal impairment, AV block. You want to make sure you take that apical pulse for 1 full minute. Hold if less than 60, and then again go with your parameters that the doctor's given you, and it shows you what the therapeutic level are and report any visual changes going back to the yellow and green halos. So Gandage toxicity, see yellow halos, pulse below 60, nausea, vomiting, low K equals high danger. So I would remember those things critically for our digoxin. Antihyperlipidemics are statins. Our biggest thing we talked about with atorvastatin, simvastatin, rosuvastatin is the myopathy, which would equal to rhabdomyolysis. The muscle pain would come about, the dark urine, again, increased liver enzymes. So you want to make sure that you tell the patient, you teach them to report that right away because it could be their muscle breakdown that's getting toxic in the body. There is also niacin, phenofibrate. So niacin can be given over the counter. So you want to make sure that you let them know to let the doctor know that they're taking it because it is over the counter. But one of the biggest adverse effects is flushing. Statins at night, muscle pain plus dark urine equals stop and report immediately. Like I said, the biggest thing to know with the statins. Um, and then give statins again in the evening. Monitor LFTs, report muscle pain, check baseline lipid panel, and teach diet and exercise. That's one of the biggest preventative ways. You also want to make sure you remember what primary, secondary, and tertiary prevention is. Um, the question can ask, like, what is this scenario? Is it primary, secondary, or tertiary? So it's very important to know when certain things are put in place. All right, moving on. And then one thing I forgot to mention with the niacin, you want to make sure that they take it with food because of the GI upset. And then we have our anticoagulants. We talked about heparin, we talked about enoxaparin, we talked about warfarin, and then with warfarin, we want to check the PTINR. With heparin, we want to check the APTT. There's also something called anti-XA that could be checked for that. Usually, tests like to talk about APTT. And then for enoxaparin, the CBC, renal function, and all of that, we want to make sure we teach about the bleeding precautions. And then for our heparin, our antidote was protamine sulfate. You want to monitor for platelet drop. And then for our enoxaparin, partial reversal with protamine, and inject in the abdomen and do not expel, air bubble, or rub this site. So a lot of the enoxaparin injections um, already have a little air bubble in them, and that's actually put in place on purpose to help guide the medication through. It's a sub-Q. You don't want to expel that air. And then with warfarin, again, vitamin K is the antidote. Um, keep vitamin K intake consistent. Don't dim, don't let them know that you can't have it at all. It's consistent. And then frequent INR checks. We also had we talked about aspirin that could be given to. You'll see a lot of elderly in the SNFs will have this 81 milligram baby aspirin. But we want to make sure that they avoid duplicate NSAIDs unless directed by the doctor and report for any black stools, vomiting blood, or unusual bleeding. Um, there's also alteplase thrombolytics that can be given, which the major risk is severe intracranial hemorrhage. This is more of like stroke has happened, they have a big clot, so there's strict eligibility time window. So you want to avoid any unnecessary invasive procedure after dose because of the bleeding risk. And then we also talked about to make sure that we get their history and physical correctly, because then they could let you know if they're taking any herbs. And then next, this is just a little healthy practice for yourself. Going on to respiratory system, we have our SABA. We talked about the short-acting beta-2 agonist, albuterol, which was our rescue inhaler. Then we have the LABA, which is our long-acting beta-2 agonist, like solumetrol and formoterol. We also have our anticholinergics, our ipratropium, our methotrexate, also theophylline. The beta-2 agonist relaxes the bronchial smooth muscle. Anticholinergics blocks bronchoconstriction. And so you want to make sure that they're not, that the albuterol will make sure that they're not as inflamed, and they're able to breathe easily. But we also want to make sure that it's not used consistently every day. It's a rescue inhaler, so it can't be given every single day. What do we want to look out for? We want to look out for tachycardia, tremor, nervousness with the beta-2, dry mouth with the anticholinergic, and then the theophylline. We have nausea, vomiting, seizures, dysrhythmias. If they have a theophylline toxicity, you want to give them activated charcoal. And then LABA, never, for contraindications, LABA never used alone in asthma. So you don't want to give them a long acting by itself. And then again, cardiac disease, hyperthyroidism. Theophylline can interact with many drugs and caffeine. So theophylline has something that would mimic caffeine. So we want to make sure that their caffeine intake is something we teach them about. Again, albuterol first. Then we have our steroid inhaler. Wait 1 minute in between the puffs. Then we have teach about the spacers and inhaler techniques, right? So we want to make sure that if needed, especially with younger children, it's harder to teach them to make sure that they close their mouths fully and inhale, and then so you have to give them the spacer to make sure most of the medication goes through. And we also want to look out for labs with theophylline. And then going back to the LABA, why it cannot be used by itself. It doesn't treat the underlying inflammation. So using it by itself is like associated with increased risk of severe asthma attacks and asthma-related deaths. So it's not really taking away the underlying issues. If you're giving it by itself, you're still going to have that bronchoconstriction if you don't give it with something else to decrease that inflammation, because they can really go back into that attack, because it only really relaxes the squeezes, so bronchodilation, but not the underlying inflammation. That's the biggest takeaway for that part. We also have our inhaled corticosteroids like fluticasone and budesonide, which is, again, a controller therapy. What would I look out for is oral candiditis. Again, we talked about with corticosteroids, we need to make sure that they're rinsing their mouth. They should be rinsing their mouth after every inhaler, but with this, the thrush is huge. We want to teach them about blood sugars going up with any kind of steroids. So again, not for acute attacks, they're controllers. Hoarseness, they want to go ahead and let the doctor know if that continues. Montelukast, we talked about, could have mood or behavior changes. And neuropsychiatric effects, again, that mood and behavior changes. And it's not for acute bronchospasm. Again, it's for everyday controller. All right, let's go to next. Antihistamines, we have diphenhydramine, which is your Benadryl. loratadine, cetirizine, as we know that they've been used very popularly with allergies. Decongestants, we have Sudafed, antitussive, we have our codeines and guaifenesin. We want to make sure that we teach the patient, especially in elderly patients, that Benadryl is a sedative, so it can impact actually anybody, not even elderly, but the diphenhydramine can impact anybody, so you want to make sure they're out driving. But with elderly, it's the falls that we want to look out for, because if they fall, they can get a fat emboli, and it could just get much worse from there on. With our decongestants, we want to, some of the key risks that are associated are hypertension, tachycardia, insomnia. So you want to avoid the use with, or use very cautiously if the doctor lets them, with hypertension, dysrhythmias, and glaucoma. Coding caution in children. Warn about drowsiness and driving with those first gens, the Benadryl. Limit topical decongestants to 3 days. And then push fluids with expectorants. And then we had a long talk about opioids, with the morphine, the hydromorphone, and the addictiveness that can happen with these medications. Respiratory depression is our biggest priority here. We want to make sure that we're looking out for their respirations before we give it their vital signs. Any kind of hypertension, because of the opioids are also very constipating. They can get a paralytic ileus, which is really bowel obstruction. So we want to make sure that we look out for things like that. And our mnemonic gives away a lot with the opioid triad, which is pinpoint pupils, low respirations, low consciousness. That is key for overdose. Narcan, we want to remember, it reverses respiratory depression, and you may need repeat dosing if they're not awake by the first one. We had talked about NSAIDs, ibuprofen, naproxen, ketorolac, how ketorolac was stronger, usually given IM or IV. NSAIDs, GI bleeding, ulcers, renal impairment are adverse effects. With aspirin, we can have the tinnitus and raise in children. Acetaminophen, hepatotoxicity, and overdose. So again, look out for the liver. To be very cautious in pregnancy. Again, in children, it has that viral illness raise syndrome. And acetaminophen, the bottle will always tell you how much you can have in one day, and to be very cautious with alcohol in conjunction. And then that ketorolac is very short term. So again, if the doctor wants it every now and then for bigger pains like back pain, that's their discretion. But it is black box warning, so we want to be very careful with it. And then we have our anti-epileptics, and then the anticonvulsants, the phenytoins, the valproic acid, Keppras, again, to get rid of the seizures, phenobarbital, gabapentin. So indication, seizure disorders, epilepsy, some for neuropathic pain, and bipolar. Um, so they want to look out for sedation, dizziness, um, any kind of ataxia. And then with the phenytoin, their gums, you could get gingival hyperplasia, rash, and Steven Johnson's with the lamotrigine and carbenzapine. So you want to make sure they look out for that. Phenytoin levels, you want to make sure that they're getting their labs done. Give IV slowly with saline only, and never stop abruptly. Maintain consistent brand. And if you stop abruptly, you're going to have those seizure activities, right? Oral care and report rash. With our mnemonic here, phenytoin, watch the gums, the gate, and the gap for the narrow window. There's no specific antidotes for these, but if they do get into like an epilepsy or if they do get in a seizure, we can give that lorazepam. That is our medication of choice. We stopped at the anti-Parkinson's um, agents. We were talking about Cinemet, carbidopa, levodopa, dopamine agonists. We have our MAO8 inhibitors used for Parkinson's disease because of the tremors or the rigidity. Drug-induced extrapyramidal symptoms. So we want to look out for those and teach the patient. They have things like dystonia, which is involuntary prolonged muscle contractions. They could have tardive dyskinesia, which is repetitive movement, involuntary movements like lip smacking and grimacing. You want to look out for those. And with Cinemet, you want to make sure that you're not giving it with protein because of the poor absorption. You want to make sure you give it without food. Um, and then raise slowly for blood pressure. Orthostatic hypotension, and we just talked about nausea, hallucination, on-off of wearing, darkened urine, and sweat. Avoid high protein meals near levodopa, right? The low absorption. We have tyramine. We talked about tyramine and how we don't want to give like fermented foods, cured foods, because they can cause hypertensive crisis. And you have that narrow angle glaucoma with the anticholinergics. Effects may take weeks. Monitor for falls and orthostasis. Do not stop abruptly, right? Take on schedule. Avoid vitamin B6 excess with levodopa alone. We want to make sure that with the Parkinson's, we give them as much supportive care as possible. Um, they do get in pain. Their tremors are sometimes really uncontrollable. So you want to look out for all of that. Anesthetics and neuromuscular blockers. We have our propofol, our ketamine, lidocaine, all of these anesthetics. Propofol was more general. Reversible anesdepression, unconsciousness, local blocks the sodium channels, and regional loss of sensation. So you have that lidocaine, the bupivacaine, and we also have the neuromuscular blockers that paralyze skeletal muscle for intubation or surgery. So you have your acetylcholine, indication like surgical procedures for the full general anesthesia. You have your regional local procedures such as things like wound care. It could be used for, uh, and then you have like epidural, the bupivacaine they really use with the epidural needle. And then the last ones, they facilitate mechanical ventilation and intubation. So things to look out for: respiratory depression, hypotension, local plus epinephrine, watch for systemic toxicity, malignant hypothermia. Want to look out for those. Those are big biggies. And then um, contraindication: lidocaine allergy, heart block, history of malignant hyperthermia. Which we were in class, I would ask you what that is. But malignant hyperthermia is a rare inherited life-threatening reaction to some of the anesthesia. So just think about like if your muscle were to get stuck in the on position. So it just contracts continuously and it produces massive amount of heat um, and tremendous amount of oxygen and energy. So common triggers are like the volatile inhaled and anesthetics, then acetylcholine that we use for the neuromuscular blocker. So you want to make sure that they look out for signs and symptoms of that. You would see things like rapid rising temperature, muscle rigidity, um, tachycardia, tachypnea, acidosis, things like that. So with our mnemonic, it says paralyzed equals pain-free, always sedate. And then with the malignant hyperthermia, we want to give them dantrolene, which blocks the calcium release from the sarcoplasmic reticulum in the skeletal muscle. So it closes that calcium faucet. This allows the muscle to relax and slow. So because of the hyperthermia, we have this just constant go, go, go. Now you need something for it to stop. So that's where dantrolene comes into play, and it allows the muscle to relax. You want to give them 100% oxygen, um, start active cooling measures. And some of our cooling measures include like cooling blankets, ice packs, cooled IV fluids if appropriate, depending on if the patient wants, not the patient, I'm sorry, if the doctor wants to do that. Monitor their EKG, their electrolytes, urinary output, and kidney function. So if a patient after surgery, you hear, suddenly develops like muscle rigidity, tachycardia, high temperature, you want to think of the malignant hyperthermia and to give them dantrolene right away. That's what they will give. So you don't want to let that calcium with the dantrolene, you don't want to let calcium out. So they could help at that sarcoplasmic reticulum to make sure that um, muscle relaxes. Our sedative hypotonics, um, benzodiazepine or lorazepam, diazepam, Xanaxes. We have our zolpidem, which indications include anxiety, insomnia, seizures, alcohol withdrawal. So the seizure, alcohol withdrawal uh, are very, very closely linked with that lorazepam. That's what helps relax everything. Um, we want to look out for any kind of sedation, any dizziness, respiratory depression, dependence and tolerance, paradoxical excitement in elderly, right? Like if you give too much, it may do the opposite of effect of what it was intended for. Um, it is contraindicated and addictive with alcohol, opioid, CNS depressants, pregnancy, severe respiratory disease, fall in older adults. So you want to make sure when they talk about benzodiazepine, it's notorious for the fall in elderly because of the sedativeness. You want to assess sedation and respirations, fall precautions, short-term use, taper, do not stop abruptly, right? Um, we have the buspirone, which takes about 1 to 2 weeks. And so Pam and Lamb calm the brain via GABA and reversal with flumazenil. It never mixed with alcohol. Never. So you want to. That would be a great patient teaching if they are going home with it. Doesn't matter which kind they're going home with. Um, Usually it would be oral, but you want to make sure that they're aware of what to look out for. And then the dependence and the tolerance is huge too. So if they're on it, you want to go ahead and assess the patient. With Bispirone, which is the Busbar, it's used for generalized anxiety disorder. So it's not for panic attacks or acute anxiety. It's more of a generalized anxiety disorder, which acts on the serotonin receptors, helping regulate anxiety. Um, it doesn't work on the GABA. Um, it helps calm the brain's anxiety signals without causing like strong sedation. So this could be used more um, on a daily basis. Takes a while to get into effect, so 2 to 4 weeks, which is this is prevention rather than rescue. Our benzodiazepines are more of a rescue. So the good thing is it's not addictive, very less sedation. There's not severe respiratory depression, and no dependence. But they can get like dizziness, headache, nausea, nervousness, lightheadedness. You want to make sure you teach them to take it consistently. Do not expect immediate relief during panic attacks, and then you want to avoid it with grapefruit as well. Our antidepressants, we have our SSRIs, our SNRIs, our TCAs, and our MAOIs. So our SSRIs are our serotonin selective reuptake, right? Um, which serotonin, as we remember, works on our mood, anxiety, sleep, and appetite, right? Um, with our serotonin norepinephrine reuptake, we have norepinephrine, which works with energy, focus, alertness, and motivation. So with people with depression, they often have too little serotonin and or norepinephrine available between the neurons, right? So we want to make sure that when the serotonin is released into the synapse, we want to block the reuptake pump so serotonin stays in the synapse longer. So because of the lack of serotonin and norepinephrine, instead of it like going back, um, we want to make sure we block those receptors so that it stays a little bit longer for them to feel the effects. So like again, to kind of reiterate that, serotonin is released into the synapse and then taken back into the first neuron, which is the reuptake, right? So then with this one, it is blocking the reuptake pump, so serotonin stays in the synapse longer. With more serotonin, you have improved mood and less anxiety. Um, and you can think of it like how I would remember it. It keeps serotonin swimming in the synapse longer. With SNRIs, or serotonin norepinephrine reuptake inhibitor. Remember the inhibitor part. What is it doing? What is it inhibiting? You have the effexor, which is the prototype drug, the venlafaxine. Some of these are so long to pronounce, but we have Cymbalta as well as one of the prototype drugs. Again, blocks the reuptake of serotonin and norepinephrine. So the difference between SSRI and SNRI is SSRI is only serotonin and SNRI is serotonin and norepinephrine. And SNRIs boost mood and energy. We want to make sure that with the adverse effect you look out for with the serotonin, GI upset, sexual dysfunction, and insomnia. We also have our TCAs like amitriptyline, our which with TCAs are are tri I can't even speak anymore, you guys. Are tricyclic antidepressants. It blocks the reuptake of the serotonin norepinephrine. Um, so just like the SNRIs, right? They increase both neurotransmitters in the synapse. And what's the difference though? It also blocks other receptors like histamines and alpha 1 receptors, which is why they have so many more side effects. So SSRIs are like laser targeted. TCAs are more like shotgun. They hit many receptors, causing more side effects. So our main uses for TCAs, or tricyclic antidepressants, is depression, neuropathic pain. We have migraine prevention, fibromyalgia, insomnia, sometimes due to sedation. Major side effects you want to remember, they're the anticholinergic effects, right? Like the can't see, can't pee, can't spit, can't poop. Um, they would have that dry mouth, blurred vision, urinary retention, constipation. It could also cause sedation, weight gain, orthostatic hypotension, tachycardia. As the biggest safety concern would be our cardiotoxicity. It could also cause arrhythmias, widened QRSs, QT prolongation, fatal overdose. Um, they have to be prescribed very cautiously, so you won't see a whole lot unless they really need it. What do you want to teach them with the TCAs? You want to teach them to take at bedtime if it causes drowsiness. You want to rise slowly due to that orthostatic hypotension, increase fluids and fibers for constipation, avoid alcohol and other CNS depressants. And the next ones we want to talk about are MAOIs, which is the monoamine oxidase inhibitor, which is an enzyme, right, that normally breaks down serotonin, norepinephrine, and dopamine. So these drugs will block this enzyme, allowing for neurotransmitters to build up. So we want to think of MAO as the cleanup crew, and MAOIS sends the cleanup crew home. Okay, so the main use is treatment-resistant depression and atypical depression, and they're not first line because of their many interactions. So the biggest concern with MAOIs is the hypertensive crisis. Remember we talked about the foods high in tyramine. They can trigger a dangerous rise in blood pressure because tyramine is normally broken down by the monoamine oxidase. So we want to teach patients about foods high in tyramine, like the aged foods contain tyramine, such as aged cheese, game or cured meats like pepperoni and salami. We have extracts, fermented foods like soy sauce, miso. You have draft beer and red wine, sauerkraut, kimchi, signs of hypertensive crisis you want to look out for, severe headache, very high blood pressure, stiffness of the neck, sweating, chest pain, blurred vision. So again, all of that is medical emergency because it's the hypertensive crisis. You also can get serotonin syndrome risk. So you never want to combine an MAOI with SSRIs, SNRIs, TCAs. So all of the depressants that you see in this group, St. John's wort, certain migraine medications such as the triptans, right? Like the sumatriptans. Um, so again, I would create a little chart between the different antidepressants to kind of see what the differences are. So just an easy memory trick I have for you: SSRIs is serotonin only, SNRIs is serotonin plus norepinephrine. TCAs is triple problem, so you have your serotonin plus norepinephrine plus many side effects, and your MAOIs, you have maintained neurotransmitters by stopping their breakdown, but avoid tyramine and dangerous drug interaction. SSRIs and SNRIs are the first line antidepressants because they're generally safe and better tolerated. And TCAs and MAOIs are older medications and they can still be very effective but require closer monitoring due to their side effects, right? So again, the side effects are huge with the TCAs and the MAOIs. For our serotonin syndrome, you want to stop taking the drug. Um, Supportive care, TCA overdose, sodium bicarbonate. So antidepressants take weeks. Watch for rising energy, lingering mood, and suicide risk was the other thing we talked about in class, I believe. With serotonin syndrome, you want to look out for that. But what is serotonin syndrome actually? It's life-threatening condition caused by too much serotonin, right, in the brain and nervous system. So now the reuptake, now there's too much floating around in that synapse. And too much of that will overstimulate your body. So um, you want to look out for symptoms such as mental status changes like agitation, anxiety. You have confusion, restlessness, um, autonomic hyperactivity like fever, sweating, tachycardia, high blood pressure, diarrhea. You have neuromuscular findings such as your tremors and hyperreflexia, muscle rigidity, um, the rhythmic muscle jerking like the clonus. So you want to look out for that. A memory trick you can remember is hot, fast, and shaky. So you have your fever, sweating, you have your tachycardia, hypertension, you have your tremor, agitation. So people with who develop serotonin syndrome, they treat them with by stopping the medication immediately, right? Supportive care, oxygen if needed, IV fluids, cooling measures for that fever. Benzodiazepines can be given to reduce the agitation as well. So SSRIs and MAOIs are high risk for serotonin syndrome. I would remember that. Again, serotonin syndrome, medical emergency caused by excessive serotonin activity. Antipsychotics. So you have your haloperidol. You have your atypical risperidone. You have your olanzapine, quetiapine, which is also known as Seroquel, suffix often done and pine, right? What are they used for? Primarily used to treat disorders with psychosis, such as schizophrenia. You have bipolar, psychosis, severe agitation. There's like Tourette syndrome. Sometimes some agents can work for that. Um, Again, like, what is psychosis, right? It is the loss of contact with reality. So those symptoms would look like hallucination, hearing or seeing things that aren't there. You have delusions, fixed false beliefs, disorganized thinking. Um, and the delusions are huge. It's not just like, you're kind of just thinking this is what it is. It's something that they becomes their reality. So psychosis is associated with too much dopamine activity in certain brain pathways. So with antipsychotics, they will block the dopamine, the D2 receptors, reducing dopamine effects. So think of too much dopamine can cause psychosis. So antipsychotics turn down the dopamine signals. So like I said before, the first gens, the typical ones, are the haloperidol, thorazine, um, and it's good for treating hallucinations, delusions, agitation. Um, Major side effect is the extrapyramidal symptoms. Our second gens are atypical, includes the ones we talked about: risperidone, olanzapine, quetiapine. They treat the positive symptoms, and negative symptoms such as flat affect, lack of motivation, and social withdrawal. Causes fewer movement disorders with typical antipsychotics, but are more likely to cause metabolic side effects. So, extrapyramidal symptoms, let's talk a little bit about that. Think about, you can't move normally, right? You have acute dystonia, you have muscle spasms, your neck is twisting, your jaw tightness, tongue protrusion. Um, Benadryl could be given for this. Benzotropine could be given for this. Um, it could look like Parkinson's disease a little bit, like tremor, rigidity. You have your shuffling gait. Um, you have you have the patient can't sit still, so they'll just have this movement that's constant movement. It's like restlessness. You have your tardive dyskinesia, usually develops after months to years. So you have things like lip smacking, tongue movements, chewing motions, facial grimacing. You also have your NMSs, which is your neuroleptic malignant syndrome. It's rare, but it could be life-threatening. Again, think of hot and very rigid. It's high fever. Um, you have altered mental status. You have autonomic instability, such as your vital signs, your blood pressure and heart rate, elevated creatinine. You have Um, so your treatment with this would be to stop the antipsychotic completely and do supportive care and dantrolene if needed in severe cases. Some other atypical antipsychotic side effects to look out for is weight gain. You have diabetes, you have high cholesterol, metabolic syndrome. Also, what I would remember is the black box warning. All antipsychotics carry a boxed warning for increased risk of death in older adults with dementia-related psychosis. So they're not approved for treating dementia-related psychosis. There's a difference. Um, it's not just psychosis. It's more of they're elderly, they're forgetting they have dementia. With Haldol, some memory tricks. Haldol equals to hallucinations but hard to move. So higher risk or EPS that we talked about. Um, for atypicals, think of atypical affect appetite. So remember weight gain and metabolic syndrome. I just want to reiterate that antipsychotics reduce dopamine activity to control psychosis. Typical antipsychotics are more likely to cause the EPS syndromes. So always monitor for serious adverse reaction, such as the neuroleptic malignant syndrome, and also remember that you want to monitor for a granulocytosis for some of this. So then the next one we have is lithium, which is your mood stabilizer. Lithium carbonate. Its narrow therapeutic index is something to look out for. So that those labs that we're going to do, it's a mood stabilizer primarily used for bipolar disorder or acute mania. So you want to have maintenance therapy to prevent manic and depressive episodes. Um, an easy way to remember it is lithium smooths out the highs and lows of bipolar disorder. So one of the most important things to look out for is the maintenance therapy levels above the therapeutic range increases the risk of toxicity. Because lithium has a narrow therapeutic index, small changes in the blood levels can lead to toxicity. So side effects to look out for: you have your fine hand tremors, mild nausea, increased thirst, increased urination, and mild weight gain. So with lithium toxicity, you want to think of the higher the lithium, the worse the neurologic symptoms. So that includes nausea, vomiting, diarrhea, coarse tremors. You have muscle weakness. Severe toxicity could go into confusion, slurred speech, ataxia, seizures, coma. You have your cardiac dysrhythmias. And dehydration and low sodium can increase lithium levels. So how does that even work? So you have the kidneys, they handle lithium similarly to sodium. If the body is dehydrated or low in sodium, the kidneys tries to conserve the sodium, and they can also reabsorb more lithium, causing blood levels to rise. So you want to teach the patient to drink adequate fluids, especially during hot weather or exercise. Maintain a consistent intake of dietary sodium, and then contact the healthcare provider if they have prolonged vomiting, diarrhea, or sweating. So there are some drug interactions to know about, and these can increase lithium levels and toxicity risk. So you have your thiazide diuretics, which is such as hydrochlorothiazide, your ACE inhibitors, such as the lisinopril, your ARBs, losartan, and NSAIDs, ibuprofen, and naproxen. So you want to always remind patients to check their healthcare provider with their healthcare provider before starting new medications, including over-the-counter drugs. Again, with lithium, you want to monitor serum lithium levels, kidney function, thyroid function, and hydration status. They want to take the lithium exactly as prescribed. Do not stop it abruptly without medical advice. Keep fluids and salt intake consistent. Have a regular blood test and report signs of toxicity immediately, such as nausea, vomiting, diarrhea, worsening, tremor, confusion, and difficulty walking. All right, next we have our CNS stimulants, um, ADHD medications, Alzheimer's. So indications include ADHD, narcolepsy, mild to moderate Alzheimer's. You have moderate to severe Alzheimer's as well. So then you have stimulants, they decrease the appetite. You have insomnia, increased heart rate, and blood pressure and growth delay. There's dependence that can happen. Bradycardia, and GI upset with the cholinesterase inhibitors. With the CNS stimulants, again used for ADHD, narcolepsy. So I'm sure you've heard of the Ritalin given, Concentra. So you have your methylphenidate, you have your amphetamine, you have your Adderall. So how are they working? They increase dopamine and norepinephrine in the brain. So these neurotransmitters improve attention. You have focus, you have alertness, concentration. So more dopamine and norepinephrine is better focus. So the Ritalin and Adderall are very popular. So side effects are anticholinergics like can't eat, can't sleep, the decreased appetite, weight loss, insomnia. They have increased heart rate, increased blood pressure, anxiety, and nervousness. So you want to give it in the morning to reduce insomnia, monitor weight and growth. In children, monitor blood pressure, assess for misuse, because there is a potential for abuse. With Alzheimer's, patients have low acetylcholine. They want a progressive loss of memory and cognitive function. So less acetylcholine equals less memory. So cholinesterase inhibitors, such as donepezil, also known as Aricept, they block the breakdown of the acetylcholine, right? Allowing more acetylcholine to remain available in the brain. So think something like protect acetylcholine to preserve memory. Side effects include, because it is a stimulant, it stimulates the parasympathetic nervous system. Think of nausea, vomiting, diarrhea, increased salivation, bradycardia, weight loss. Memory trick to remember is sludge, which is your cholinergic effects. Salivation, lacrimation, you have urination, you have diarrhea, GI upset, and emesis. So you want to let them know to take it with food, monitor pulse before administration, and to report any dizziness. We also have our NMDA receptor antagonist, which is like memantine, Namenda, which you'll see a lot in the SNPs as well. It blocks the excessive glutamate activity, which helps brain protect cells from further damage. So you want to think about protects brain cells from overstimulation. Okay, so side effects include dizziness, headache, confusion, and constipation. Again, these medications do not cure Alzheimer's. So Alzheimer's is not curable, but these medications may help slow the symptom progression, and it temporarily improves cognition and daily functioning. So again, I just want to do a little overview again of CNS stimulants. It increases dopamine and norepinephrine, whereas in Alzheimer's medication, it increases acetylcholine. And then with CNS, you have improved attention and focus. With Alzheimer's, you have helped preserve memory and cognition, right? With CNS, you have used for ADHD and narcolepsy. Alzheimer's is for Alzheimer's. And then for CNS, you want to look out for insomnia, weight loss, and higher heart rate and blood pressure. With Alzheimer's, you want to look out for nausea, diarrhea, bradycardia, dizziness. So with stimulants, you want to remember stimulants speed everything up. So somebody with ADHD, they'll have stimulants. It increases heart rate, blood pressure, alertness, right? Because they want to have more alertness. And then with donepezil, it doesn't cure, it delays decline. Donepezil equals more acetylcholine. Watch for bradycardia and GI upset. Memantine maintains memory. All right, so the next one, we have our endocrine system. So endocrine system is where our diabetes is, right? You have your different insulins, the Lispro, the Aspart, you have short acting, regular, intermediate, NPH, long, glargine, and Detamir. So what are the biggest things we want to look out for here? So type 1 diabetes, right? It's required because you have the total destruction of the beta cells. And then for type 2 and gestational diabetes, you can have medications. And then DKA and hyperglycemic emergencies. And we know that regular can be given IV. That's the only insulin that can be given IV. So insulin is the key that unlocks the cell. So glucose can move from the bloodstream into the cells for energy, correct? So insulin lets sugar leave the body and enter the cells. So we have our rapid acting, which is the Lispro, and the Aspart, the Novolog. With that, a good memory trick is right now. We want to give it right now. Lispro usually is connected with the sliding scale. So after the patient, we take their blood sugars, depending on what it is, and we want to make sure that they have food or something coming or close to them in case they go into a hypoglycemic state. You have your short acting, which a good memory trick is regular IV insulin. Intermediate is like NPH. So it's cloudy. That's a way to remember that one. Long acting or Lantus or the Glergin. So long it lasts all day, given at night usually. We want to remember clear before cloudy, right? So adverse effects, you want to look out with the hypoglycemia, the priority adverse effect, weight gain, the lipohypertrophy at all sites, hypokalemia shifts potassium into the cell. So again, regular insulin, only insulin routinely given IV used for DKA, the diabetic ketoacidosis. Hyperkalemia given with dextrose and critically ill patients. With the NPH, you want to remember NPH is cloudy. Roll gently, do not shake. When you mix, it's clear before cloudy. So draw up the regular, which is clear, and then the NPH cloudy. Clear before cloudy. Injection sites, best absorption. You have the abdomen, which is the fastest and more consistent. Arms, thighs, and buttocks. You want to let the patient know that you're rotating injection sites within the same area to help maintain consistent absorption while reducing the bruising. You have hypoglycemia, anything below 70. Usually you will have parameters for that. Some symptoms to look out for. You have cold and candy. My bad. Cold and clammy, needs some candy, is hypoglycemia. So you'll see sweating, shaking, hunger, tachycardia, anxiety, irritability. Later symptoms are like confusion, slurred speech, total loss of consciousness. With treatment, patient awake and able to swallow. You want to do the 15-15 rule. So give 15 grams of fast-acting carbs. That could include 4 glucose tablets, 4 ounces of fruit juice, 4 ounces of regular soda, not diet, and recheck blood glucose in 15 minutes and repeat if it's still below 70. If patient is unconscious and cannot swallow, they need to go to the hospital. They'll be given IV dextrose, the D50. Outside of the hospital, they can have the glucagon, which is by injection or nasal formulation. With hyperglycemia, a good way to remember is hot and dry, sugar high. So you'll see increased thirst, frequent urination, dry mouth, blurred vision, fatigue. If it gets really severe, you can see something like diabetic ketoacidosis, which usually is with type 1, and then hyperosmolar hyperglycemic state with type 2. Some of our priorities is to check the blood glucose, verify the correct insulin dose and timing, ensure the patient has the meal available, correct, appropriate, especially for rapid acting. Then we have here any contraindications do not give if we're already having a hypoglycemic issue. Beta blockers mask hypoglycemia. So if they have beta blockers, they could mask the hypoglycemia sign. So it could be life-threatening illness / steroids rise the glucose needs. So know the onset peak. Teach eating around the peak. Rotate the injection site again. Recognize hypoglycemia. So we have our non-insulin anti-diabetics. You have your metformin, which is the first line. The bigunide is the class. You have your glipizides, the gliberides. You have GLP-1s, and you have other medications as well. And we talked about metformin and what to look out for that. The biggest thing was the contrast diet, correct? So they need to make sure that they are stopping that prior to getting any kind of procedures. So you have what does metformin do and what is the goal? And that is decrease hepatic glucose and increase insulin sensitivity. So essentially what it's doing is it's stopping the release of glucose from the liver. So when you eat when you're eating, it's not exerting out extra. And it does not stimulate insulin release. So it's the first line for type 2, weight neutral or modest weight loss. You have low risk of hypoglycemia when used alone, but side effects are diarrhea, nausea. You have those really big GI effects, abdominal discomfort. This is rare but can happen is the lactic acidosis. Avoid with kidney disease dysfunction, right? We talked about how it's so bad for the kidneys. It's very nephrotoxic. Hold metformin before any contrast. And then again, metformin makes the liver make less sugar, right? So essentially not letting it come out of the liver. And then you have your sulfonylurea gas, the sulfas It's the glipizide. You have glyburide, the glimmeride. Um, this helps stimulate the pancreas to release more insulin. Side effects include hypoglycemia, which is huge, weight gain. You want to make sure they're eating their meals regularly. They're carrying a source of fast-acting glucose. With the sulfas, you have the squeezed insulin out of the pancreas. That's what it does. We also have Januvia, which is acetagliptin. It increases hormones, which helps increase insulin release after meals, decrease glucagon release, and it's usually well tolerated. You have your GLP-1s, which are semaglutide, like Ozempic and Wegovy. It contains, it's semaglutide, but it's approved for weight management now. As we know, a lot of people do take it. How do they work? They increase insulin secretion when glucose is elevated, slow stomach emptying, and reduce appetite, which in turn decreases the glucagon release. We also have Jardians, which they help the kidney remove excess glucose by increasing urinary glucose excretion. So you have the SGLT2, which is equal to sugar leaves through the toilet. That's the way to remember that one. Benefits increase weight loss, mild blood pressure reduction. Some agents help with the risk of heart failure, hospitalization, and slow the progression of chronic kidney disease. Side effects of these include increased urination, urinary tract infection, dehydration. So some memory tricks to remember these drugs is metformin is equal to makes less sugar. You have your sulfa, squeezes insulin out. The GLP-1s get less plate food, which reduces the appetite for the Ozempics and the Wegovys. You have SGLT2 inhibitors. Sugar goes out into the toilet. And then next, we have thyroid and anti-thyroid agents, which replacement for hypo is levothyroxine. And then you have your anti-thyroid methimazole, PTU for hyper. And you also have iodine, beta blockers, radioactive iodine conjunction medications. So with thyroid, you want to remember that it controls your body's metabolism. So think of it as like a gas pedal for the body. Too little thyroid, body slows down, right? That's your hypo. And too much thyroid, your body speeds up. So hyperthyroid. So for hypo, everything is slow. So you have fatigue, you have weight gain, cold intolerance, constipation, dry skin, depression, and slow heart rate, bradycardia. Thyroid hormone replacement medication, levothyroxine. It is a synthetic T4, right? Because we have low T4, and it replaces the thyroid hormone the body isn't making. So think of levothyroxine replacing what the thyroid is lacking. So you want to take it the first thing in the morning, take it on an empty stomach, and take with water. Wait 30 to 60 minutes before eating. And you want to separate it from calcium, iron, and antacids by several hours because they can decrease the absorption. What do I want to look out for? If the dose is too high, the patient may develop hyperthyroidism, right? So now they have too much hormone. So you'll see like fast heart rate, palpitations, weight loss, anxiety, you have insomnia. And you want to let the patient know that they will be taking this for the rest of their life. So you do not want to stop it without letting your provider know, or you really shouldn't be stopping it because it is a lifetime medication. But they need to talk to their healthcare provider, and it may take several weeks to notice the full effect. For hyperthyroidism, everything is fast: heat intolerance, sweating, tremors, you have anxiety, you have diarrhea, you have tachycardia. So we like to give methimazole, tapazole, um, and another important drug is the PTU. So what does it do? They reduce the production of the thyroid hormone, right? So anti-thyroid drugs turn down the thyroid. So the major side effects you want to look out for is the granulocytosis, which is dangerous decrease in the white blood cells. So you want to teach the patient to report any kind of fever, sore throat, signs of infection. Liver toxicity can happen with PTU, which has a higher risk of serious liver injury than methimazole. So patients should report like yellowing of the skin or eyes. You have dark urine, severe fatigue, and you have abdominal pain. How are these drugs working with hyper? With your PTU, you have decreased the conversion of the T4 and the T3, right? Because it's too high. With methimazole, it's primarily the TSH production. With PTU, you have higher risk of liver toxicity. And PTU, sometimes they can use it in pregnancy, but it has to be like around the first trimester. And with methimazole, it's often preferred after the first trimester and in non-pregnant adults. Thyroid storm, things we want to look out for: a medical emergency, which is caused by severe untreated hyperthyroidism. Symptoms: very high fever, that granulocytosis kicks in, extreme tachycardia, agitation, confusion, hypertension that may later progress to hypotension. So we need things like beta blockers to help with the extreme tachycardia, iodine, supportive care, PTU. So with levothyroxine, just think of low thyroid, give levo. Another name is synthroid. Methimazole, think of methimazole makes less thyroid. Hyperthyroidism, you want to think of fast. Everything is fast. Hypothyroidism, you want to think of everything is slow. Okay. Next, we have our systemic corticosteroids, such as prednisone, methylprednisone, hydrocortisone, dexamethasone. So what do? Systemic corticosteroids are powerful anti-inflammatory and immunosuppressive medications. Um, they don't cure it, but they reduce the body's inflammatory and immune response. Uh, how I like to remember it is that steroids calm the immune system. Some of the common uses, there's a lot of uses for steroids, like asthma exacerbation, you have COPD exacerbation, your allergic reactions, autoimmune disease, rheumatoid arthritis is an example of the autoimmune disease, inflammatory bowel disease, cerebral edema, adrenal insufficiency. So they reduce inflammation, swelling, and immune activity. So something to think about is less inflammation is equal to easier breathing, less pain, and less swelling. Though I do want to remember what the biggest side effects is, right? You have, think about Cushing. So with steroids, they can get cataracts, ulcers, sugar increases, like the hyperglycemia, hypertension, infection risks increases, necrosis of bone. It's rare, but it can happen. You have glaucoma, weight gain, mood changes, insomnia, fluid retention. Think of easy bruising. So, how does steroids raise blood sugars? They stimulate the liver to produce more glucose and make the body's tissue less responsive to insulin. So, even patients without diabetes may experience elevated blood sugars. Um, they also increase infection risk, right? They suppress the immune response. So, you want to teach your patients to report fever, chills, persistent sore throat, any signs of infection. So, and an important nursing teaching is to take with food, help reduce stomach irritation, take in the morning. Um, this best matches the body's normal cortisol rhythm and may reduce insomnia. And they don't want to stop it suddenly, right? We want to taper long term. Steroid use suppresses the adrenal glands, so stopping abruptly can cause adrenal insufficiency. So you'll see like severe fatigue, hypotension, weakness, shock in severe cases if they've been taking it for a very long time. A long-term use, you want to monitor for osteoporosis, again, cataracts and glaucoma, a weight gain, hyperglycemia, you have hypertension, increased infection risk. Um, if a patient is on long-term therapy, they may need calcium, vitamin D. They want to be told to do weight-bearing exercise for that osteoporosis, bone density monitoring as well. Steroids and asthma, use systemic. We have like prednisone, methylprednisolone, um, acute asthma exacerbation, severe inflammation. Um, Another memory trick for steroids, you want to think of sugar and salt and sick. So hyperglycemia, salt retains, so you have that fluid retention, hence you have the hypertension. Sick, so you're prone to infections risk. And then never stop suddenly. Steroids must slowly step down. Next, we have bone agents and reproductive hormones. What do I want to remember for that? So, with bone agents, what are they used for? They're used to help prevent osteoporosis, treat osteoporosis, reduce fracture risk, and improve bone strength. So, think of strong bones need calcium. Osteoporosis medications either build bone or slow the bone loss. We have alendronate, Fusamax, which works by slowing the bone breakdown by inhibiting osteoclasts. So you want to think of um, bisphosphonates stop bone destruction. So major teaching would be take first thing in the morning with a full glass of water and an empty stomach. They want to remain upright for at least 30 minutes, and you tell them to not eat, drink anything except water, or take any other medication during that period. That will help prevent esophagitis and improve absorption. They can get heartburn, bone pain from it. So that's why you want to make sure that they're following directions of how it's supposed to be taken. With calcium and vitamin D, calcium builds up in the bone, and vitamin D helps absorb calcium. So you want to teach them to take vitamin D consistently. Calcium is often better absorbed in divided doses. We have calcitonin, which is not as used. It's not as common, but it helps lower blood calcium, slow bone loss, and may reduce pain after some Um, Fractures. Calcitonin usually is given nasal. For Fosamax, you want to remember sit up, full glass of water, stay upright, and empty stomach. Okay. And then for some of the reproductive hormones, you have estrogen, which is used for menopause symptoms, hormone replacement therapy, and some contraceptives, correct? Um, Major concerns, blood clots. Estrogen is equal to clot risk. So you want to watch out for any DVT, any pulmonary embolism or stroke. You want to teach the patient to report any leg pain or swelling, chest pain, shortness of breath, or sudden vision changes. And then progestins for your progesterone. Examples include medroxyprogesterone. Um, it's birth control. You could use it for abnormal uterine bleeding and its endometrial protection. Side effects include weight gain, mood change, irregular bleeding. Combination oral contraceptives, they contain both estrogen and progesterone. They work by preventing ovulation, thickening cervical mucus, and altering the uterine lining. You want to teach them to take it at the same time every day. I've seen women put like an alarm clock for their contraceptives. If one pill is missed, you want to follow the package instructions or your healthcare provider's direction as recommended. Recommendation may vary on the type of pill and how many are missed. Um, Serious side effects, you want to remember aches. They could have abdominal pain, chest pain, headache, eye problems, and severe leg pain. So these may indicate like a blood clot or other serious complication. Then we have testosterone, which is used for male hypogonadism, delayed puberty, some gender affirming hormone therapy. Side effects include acne, fluid restriction, you have polycythemia, which is the increased red blood cells, possible infertility due to decreased sperm production. So you want to monitor for hematocrit, PSA, and liver function. There's erectile dysfunction drugs such as sildenafil. Remember not to take sildenafil with nitrates. Um, it increases blood flow to the penis. So you never combine with, again, nitrates. This combination can cause severe hypotension. So to sum it all up, the bisphosphonates, bone pill before breakfast, estrogen, E for embolism, so remember clot risk, birth control, aches, remember abdominal pain, chest pain, headaches, eye problems, severe pain, and then sildenafil blue pill plus nitroglycerin equals to blood pressure bottom out. Next, we have the GI system. So you have your anti-ulcer and acid reducing agents. So we have our PPIs, our proton pump inhibitors, such as omeprazole, pantoprazole. Um, Too much stomach acid damages the stomach and esophagus, so these drugs will help reduce acid and protect the stomach. So proton pump inhibitors, you have your omeprazole. Um, they block the proton pump in the stomach, which is responsible for the final step of acid production. So you want to think of PPI as shut off the stomach's acid pump. So uses are GERD, peptic ulcer, H. pylori treatment with antibiotics. So side effects I want to look out for. The mild ones are headache and diarrhea. Long-term use increases the risk of osteoporosis-related fractures, vitamin B12 deficiency, low mag, and C. diff infections. So you want to teach them to take this 30 to 60 minutes before breakfast or before the first meal of the day. They want to swallow capsule whole unless products um, allows opening or sprinkling. We have our H2 receptor blockers, the famotidine, such as Pepcid. They work by blocking histamine 2 receptors in the stomach, reducing acid secretion. So you want to think of like histamine tells the stomach to make acid. H2 blockers block that message. So again, this has the mild side effect of headache and dizziness. Antacids such as Tums, milk of magnesia, you have aluminum hydroxide. They neutralize the stomach acid that is already present. So think about antacids. Don't stop acid, they soak it up. Magnesium side effect is diarrhea, aluminum is constipation, and then calcium is constipation as well. You want to let them know to take antacids at least 2 hours apart from many other medications because they can decrease absorption. We also have Carafate. And what does Carafate do? It's a coat of armor. So you have, it forms protective coating over an ulcer. So you can also think of it as a bandage for the stomach. You want to take it on an empty stomach before meals and bedtime. Separate it from other medications by 2 hours because it can interfere with their absorption. So remember, Carafate is a suit of armor. Um, Cytotec, which is also an OB med, but it could be used for NSAID-induced ulcers. We have our H. pylori treatment. Includes PPI, 2 antibiotics usually. Lifestyle changes they have to make, like avoid smoking, excess alcohol, large late night meals, food that worsen symptoms. So with GERD, they want to elevate their head of bed, maintain a healthy weight if appropriate. So memory tricks, PPIs, pump off, omeprazole, pantoprazole, so they end in zols. H2 blockers such as famotidine blocks histamines and acids neutralized now. Carafate is a stomach bandage or the suit of armor. And then misoprostol plus pregnancy equals no. PPIs are most effective acid suppressors. Carafate should not be taken with other medication because it reduces their absorption, and antacid interferes with many medications. Separate them at least 2 hours in between. Misoprostol is contraindicated during pregnancy, and treat H. pylori ulcers with antibiotics plus a PPI. Next, we have antiemetics and prokinetics, which includes what is antiemetics? For one, it's to stop nausea and vomiting, right? Antiemetic, anti-vomiting. Prokinetics increase movement of the GI tract. So you want to think of promote, kinetic is movement. So they help move food through the stomach faster. We have antiemetics such as ondansetron, which is Zofran, uses chemotherapy-induced nausea, post-operative nausea, and general nausea and vomiting. It's blocking the serotonin receptor in the brain and GI tract. So you want to think of it like Zofran blocks the vomiting signal. Some side effects include headache, constipation, dizziness. QT prolongation as well. It can increase the risk of torsades de pointes, especially in patients with congenital long QT syndrome. So we want to look out for that. It's a major lookout for Zofran. You have promethazine, phenergan, motion sickness, nausea, vomiting is its use. Side effects include drowsiness, dry mouth, hypotension. You want to teach the patient to avoid driving or operating any vehicle. Scopolamine patches. So there are transdermal patches behind the ear. It helps with motion sickness. They also give it during surgery. I've seen patients come up with the little patches behind their ears. You want to remember anticholinergic side effects: dry mouth, blurred vision, and drowsiness. Prokinetic, Reglan, metoclopramide. Remember we talked about it last week, where it helps the GI tract move. It could be used for gastroparesis, GERD, nausea, and it works with increasing the stomach emptying, increases GI motility, increases lower esophageal sphincter tone. You have Reglan gets the stomach moving again. That's how I would remember that. Side effects includes EPS. Remember, it was the extrapyramidal symptoms because it blocks the dopamine. Um, that is for that one. So ways to remember. Let's see. Zofran, you can remember with the Z, zero vomiting. Metoclopramide, Reglan regulates the stomachs. Scopolamine, seasickness patch. Promethazine, remember sedation. We have our laxatives and antidiarrheals. We have like bulk laxative, which is psyllium. Osmotic, we have our Miralax. Um, there are other medications that are much stronger as well, but laxatives help a patient have bowel movement. Think of laxatives, move poop out. Antidiarrheal, slow bowel movement to stop diarrhea. So bulk farming, such as the psyllium, the metamucil, they absorb water and make the stool larger, softer, and easier to pass. So bulk equals bigger, softer, and softer stool. So you want to teach the patient to drink plenty of water. Without enough water, there's a risk of choking or a bowel obstruction. With stool softeners, you have docusate the colace. They allow water and fat to mix in the stool, making it easier to pass. So you want to think of colace as it makes the stool soft. You have stimulant like Senecot, Odocolax, which helps stimulate intestinal muscle to increase bowel movements. So think of stimulants as squeeze the bowel. Osmotic laxatives such as Miralax. Other examples include like lactulose or Micomag. They pull water into the intestine to soften the stool. So osmosis pulls water into the bowels. That's a way to remember that. With lactulose, it's usually used with somebody with too much ammonia in the body and it pulls the ammonia and they poop it all out. But it can be used with severe constipation as well. With antidiarrheals, you have Imodium. Oops, sorry. Oh, it's not going back. But with the antidiarrheals, you have loperamide, Imodium. It slows the intestinal movement, so the more water is absorbed. You want to think of Imodium slows the intestines. Side effects is constipation, dizziness, abdominal discomfort. You want to make sure that they do not use diarrhea with bloody stools high fever, or like bacterial infection, because slowing the bowel in these situations can actually worsen the illness. So you don't want to keep it in, right? We have Pepto-Bismol, diarrhea, upset stomach, nausea. It could cause black stools. So you want to include in the teaching for the antidiarrheals is avoiding children and teenagers recovering from viral illnesses such as risk of Rye syndrome because it contains salicylate. Remember with the aspirin. Patients with active bleeding disorders unless advised by the healthcare provider. Nursing priorities for our constipation includes increased fluids, increased fiber, and you want to encourage exercise. For diarrhea, you want to replace fluids, monitor electrolytes, and watch for dehydration. So some easy memory tricks for these drugs include, for psyllium, plenty of water with psyllium. Colace equals comfortable stool. Senna is a stimulant. It stimulates. Miralax, more water equals more poop. Imodium, I equals intestines slow. Pepto paint, and then for Pepto paints the stool black. Those are easier ways to remember. Again, with the psyllium, bulk forming laxatives requires adequate water intake. Docusate prevents straining. Long-term stimulant laxatives can lead to dependence. And then do not use loperamide for bloody diarrhea or diarrhea with high fever unless prescribed. So somebody that has a lot of scar tissues, a lot of surgeries, they are usually at risk for bowel obstructions, like complete bowel obstructions. So we want to make sure that they're not getting constipated. So the doctor will put them on softeners, and there are some softeners that are stronger, like Linzess, that the patient needs to be on all the time to make sure that they don't get another obstruction. Next, we're going to talk about anti-infectives. We're almost there, you guys. We have our cell wall agents. So what are they? Anti-infectives are medications that kill bacteria, correct? So it stops bacteria from growing. One of the biggest things I want everybody to remember is antibiotics do not treat viral infections. Antibiotics, the viral infections, so such as common colds or influenza, it's not going to treat that. Bacteria equals antibiotics, viruses, no antibiotics. So remember that. So bactericidals kills bacteria. So some of the examples include penicillin, cephalosporins, vancomycin. Suicidal is homicide, so it's killing. So killing the bacteria, excuse me. A lot of people are allergic to penicillin, so you want to make sure that if they're allergic to penicillin, they're not getting anything that contains the structure of what's going on with that beta-lactam ring. Cephalosporins mimic penicillin, so if somebody has a penicillin allergy, they won't get cephalosporin. The doctor has to opt out for something different. Bacteriostatic, we have stops bacteria from growing. Examples include tetracyclines and macrolides. So static is stop. Penicillin prototype is amoxicillin. So some uses are strep throat, ear infection, pneumonia, skin infections. Some major side effects you want to look out for: that allergy, the rash, the anaphylaxis. For cephalosporins, we have Keflex, cefazolin, rocephin. So again, the major point here is patients with severe penicillin allergy may also react to cephalosporins. So you want to make sure you assess that and let the doctor know. We have macrolides such as azithromycin, Zithromax. There's erythromycin, clarithromycins. Which may cause GI upset, QT prolongation. And then you have tetracyclines, which is like doxycycline. Their uses include acne, Lyme disease, chlamydia, and tick-borne illnesses. So important teachings with the tetracyclines that you may see on your exam is do not take it with milk, calcium, iron, antacids. These decrease the absorption. So you want to avoid excessive sun exposure as well because they can cause photosensitivity. Not recommended during pregnancy. Okay. We have fluoroquinolones, which is like ciprofloxacin, Cipro. There's also levofloxacin. The major side effect with fluoroquinolones is equal to, I could say it, tendon rupture. Tendinitis. So if a patient comes in with tendon issues, you want to look out for any QT prolongation, risk of peripheral neuropathy. So again, teach patients to report sudden tendon pain or swelling. Sulfamides, we have your Bactrim. So we have rash, photosensitivity, crystals in the urine. So you want to teach with sulfamides for patients to drink plenty of water. Aminoglycosides such as gentamicin. We want to think of odo plus nephro. So think of ototoxicity and nephrotoxicity with aminoglycosides. We want to monitor for their hearing and kidney function. Vancomycin is used for MRSA or serious gram-positive infections. So major side effect with vancomycin is the red man syndrome caused by infusing medication too quickly if it's given IV. So symptoms include flushing, redness, itching. What do I want to do? I want to stop the infusion, right? Also monitor the kidney function. We want to make sure some of the teachings that we give is even if you feel better, you want to finish the entire prescription and take exactly as prescribed. And you want to report severe diarrhea because it can cause C. diff, right? That good bacteria taken out of the GI system. Some antibiotics do decrease the effectiveness of hormonal birth control, so you want to let the patient know that that's something that can happen. So some memory tricks. Penicillin is equal to pen allergy, doxycycline. You don't drink dairy because it is a tetracycline. Ciprofloxacin, Cipro can injure the Achilles, so we have that tendon rupture. Gentamicin, gentle on bacteria, not on kidneys or ears. Remember, odo and hepatotoxicity. Nephrotoxicity. Vancomycin, very red if infused too fast. Excuse me. You want to remember all of that? Oh, I think I already went over that. Forgot to change the slide with that. And the next one we have anti-tubercular agents. And this is really for, it's your TB medication, right? Tuberculosis, an anti-tubercular agent. Um, because tuberculosis is caused by bacterial infection, right? By Mycobacterium tuberculosis. It usually affects the lungs, but it can affect other organs. So think about like TB is slow growing, so it requires long-term treatment with multiple antibiotics. So the first line, you want to remember the acronym RIPE, which is rifampin, isoniazid, which is pyrazimide, and ethambutol. So it's a lot of medications to pronounce and a mouthful. So you just want to remember some easier ways like RIPE. These four medications are they're started together for active TB. And then with isoniazid, the INH, it helps kill actively growing TB. So some of the major side effects to look out for is hepatotoxicity. So with hepatotoxicity, you want to look out for like yellow skin, right, or eyes, dark urine, and right upper abdominal pain. So you want to monitor those liver function tests. Also, peripheral neuropathy could cause numbness, tingling, burning of the hands and feet, right? We want to give B6 to prevent that. So with INH, needs help. So with INH, you need vitamin B6, which is, if you don't have that, you're going to get that numbness, the tingling, the burning in the hands. For rifampin, uses for TB and other bacterial infections. One of the major things to remember with rifampin is the orange, red, bloody fluids. So you could have your orange colored urine, sweat, saliva, tears. This is expected and it is harmless. You want to let the patients know. Soft contact lenses may become permanently stained. Other side effects include hepatotoxicity. Many drugs interact because rifampin induces the liver enzyme, which can reduce the effectiveness of the medication, such as like warfarin and hormonal contraceptives. So you want to let them know that as well, and kind of look at their history that if they're taking this medication. Another kind of medication, you have the pyrazinamide, which is another medication for TB. Major side effect includes hepatotoxicity, cause high hyperuricemia. So you want to monitor for those liver functions and uric acid levels. Ethambutol, we have a major side effect is optic neuritis. So you'll see something like blurred vision. You have decreased visual acuity, difficulty distinguishing red from green. So you want to teach the patient about vision changes immediately. And that they should report them, immediately. So why are our TB patients taking so many drugs? Because TB bacteria develop resistance easily. So you want to use multiple medication to improve treatment success, reduce drug resistance, and help eliminate the bacteria in different growth phases. So you also want to make sure that they're told about the long-term therapy and use the N95 correct, because it is an airborne illness. So it usually takes about 6 months, and patients have to complete the full course. Right, almost there, guys. Almost there. We have your antifungals and your antivirals, right? Because you can't use antibiotics for colds. So with antifungals, and what is the difference, right? So with antifungals, You treat fungal infections like yeast infections. You have like ringworms, athlete's foot, oral thrush, like systemic fungal infections. Um, so fungi needs antifungals, not antibiotics, right? So antivirals, though, they treat viral infections by slowing viral replication. They can't kill viruses, but they can help them stop from multiplying. So antivirals can slow the virus down so the immune system can catch up. You have fluconazole, like diaflucan, for vaginal yeast infection, oral thrush, candida infections. So some of the side effects include like nausea, headache. You want to think of hepatotoxicity with this drug. You want to monitor their liver function in yellowing skin and dark skin. Um, Also, nystatin for oral thrush. You want to teach them to swish and swallow, and do not eat or drink immediately afterwards. The medication has time to work. You have your amphotericin B, uses for serious systemic fungal infection. You want to think of ampho as like terrible. And the biggest thing with this one is the nephrotoxicity, fever, chills, electrolyte disturbances, especially low potassium and low magnesium. So you want to monitor for kidney function, potassium, magnesium. I know I'm going really fast, you guys. I'm trying to just get it all in before the video becomes too long. So with ampho, think of terrible nephrotoxicity. Antivirals, you have acyclovir, uses are like herpes simplex, virus shingles. You can have chicken pox with which is varicella. How does it work? It stops the viral replication, right? So major side effect is kidney injury, especially with IV therapy. You want to teach the patient to drink plenty of fluids. We have Tamiflu, which I'm sure you've heard of. It's for flu influenza and works best if started within the 48 hours of symptom onset. You have your HIV medications, the tenofovir. These medications control HIV, lower viral load, improve immune function, but they do not cure HIV. Patient has to take it every day to reduce the risk of treatment failures and resistance. Again, a memory trick. Info B is info terrible. So you want to remember terrible for kidneys and monitor electrolytes. Acyclovir, avoid kidney problems by drinking fluids. Tamiflu, time matters, right? So you want to start within that 48 hours. Nystatin, swish before you swallow. It's when prescribed as an oral suspension or oral candiditis. And then HIV medications must be taken consistently. They suppress the virus, but they does not eliminate it. Do these, please make sure you're doing these HESI practice questions. So next you have your musculoskeletal relaxants, right? Muscle relaxants such as Flexeril. We have gout medications and your DMARDs. So let's start with this muscle relaxant: cyclobenzaprine, baclofen, gout alpurinol, colchicine, DMARDs, methotrexate. So for skeletal muscle relaxants, what are they used for? They're muscle spasm, acute back pain, you have muscle injuries. So you want to think of muscle relaxants, they relax the muscle, but they don't fix the injury. Sometimes they have muscle relaxants accompanied, in between times with an opioid to help with that pain. So cyclobenzaprine, the Flexeril. Some of the side effects you want to remember that relax is sleepy, right? So drowsiness, you have dizziness, you have dry mouth, weakness. Baclofen is used for multiple sclerosis, spinal cord injuries, and severe spasticity. So with baclofen, you do not want to stop it abruptly, right? Because you can have sudden withdrawal, can cause like hallucination, seizures, and so you want to teach avoid alcohol, do not drive until you know how the medication affects you, and use caution with standing due to the dizziness because that relaxed sensation. And then the gout, you have gout occurs with the uric acid buildup, right, in the joints, which causes severe inflammation. So most commonly affects the big toe. Think too much uric acid, painful crystals, right, in the joint. Colchicine, it works by reducing inflammation caused by uric and acid crystals. So side effects include diarrhea, nausea, vomiting. NSAIDs often first line for an acute gout attack. So indomethacin, naproxen. So, long-term prevention is allopurinol, and it decreases uric acid production. So think about allopurinol lowers uric acid. And an important teaching for this medication includes do not start allopurinol during an untreated acute gout unless directed by the healthcare provider. Starting or changing your rate lowering therapy can initially worsen a flare, and you want to make sure they're drinking plenty of water. Some other side effects include rash. They could have hypersensitivity reactions. It's rare, but it can happen. DMARDs, disease-modifying anti-rheumatic drugs. So DMARDs slow the progression of autoimmune disease rather than just relaxing the symptoms. So it's used for like rheumatoid arthritis. We have autoimmune conditions. So you want to think of DMARDs don't just reduce pain, they slow the joint damage. So methotrexate is one of the most common first-line DMARDs for rheumatoid arthritis. Some side effects include bone marrow suppression, so you want to monitor through CBC, liver toxicity, so hepatotoxicity. You want to monitor for liver function tests, mouth sores, stomatitis, so you want to give folic acid. So think of methotrexate plus folic acid are friends. Methotrexate is tetragenic, so it can't be given in pregnancy. Humira, I'm sure you've heard of in the ad. That's another DMARD. Some side effects include increased risk of serious infection. Patients should be screened for TB before starting the therapy. So some memory tricks I want to give you. Flexeril makes you flex into bed. Remember sedation. Baclofen, back off baclofen slowly. So taper, don't stop suddenly, right? Colchicine cleans up the flare. So you want to use for acute attacks. Allopurinol, all lower, so lowers uric acid. Methotrexate, need folic acid. So that's something that I would remember with those. Hematologic. Just as it sounds, it has to do with your blood. So anemia and hepatopoietic agents. So here we have iron, ferrous sulfate, vitamin B12, folic acid, erythropoiesis such as epotin alpha, filgrastim. So with anemia, we don't have enough healthy red blood cells or hemoglobin to carry oxygen. So think of like no iron, no oxygen, no energy. So symptoms of anemia include tired, right? Think of tired. Write it down, like spell it out. We have tired fatigue, intolerance to exercise, rapid heart rate, right? You have that tachy, exertionals, shortness of breath, and dizziness. Also pale skin, headache. Types of anemia, you have iron deficiency anemia, which is the most common. So with that, we would give iron sulfate. Ferrous sulfate. So with ferrous sulfate, it provides iron to make hemoglobin, right? Side effects, constipation is huge with any kind of iron, and dark and black stools, and nausea. So iron does turn your stools dark and black. A good teaching is to take it with vitamin C, right? It improves the absorption. You want to avoid taking it with milk or other calcium supplements, antacids. Those decrease the absorption. So liquid iron, use a straw and rinse the mouth afterward because it can't stain the teeth. Vitamin B12, usually given by injection with deficiency um, due to impaired absorption, right? Pernicious anemia, right? That's linked to B12. So some patients may be treated with high dose oral therapy. So you want to remember some symptoms of B12 deficiency is fatigue, numbness, you have tingling, you have balance problems. Folic acid deficiency, it's important in pregnancy, correct? In poor nutrition and alcohol use disorder. Hematopoietic agents such as epotin alpha, epogen. What does it do? It stimulates the bone marrow to make more red blood cells. So think of EPO, extra red blood cells. Uses are like chronic kidney disease, chemotherapy-related anemia. So some nursing considerations to look out for is you want to monitor their hemoglobin, blood pressure. Hypertension is a major side effect. So if the hemoglobin rises too high, then there's that increased risk of blood clots. Neupogen, the filgrastim, what does that do? It stimulates the production of white blood cells. We usually give this in conjunction to chemotherapy. It's used for chemotherapy-induced neutropenia. So side effect is like bone pain. So some of these memory tricks to remember: iron equals orange juice, right? It helps with the absorption. EPO, extra RBCs. Filgrastim fights infections, right? So makes neutrophils. And then iron turns stool black, and this is expected. I would encourage you to look at some of your lab values for hemoglobin. You know that female and male are differ. Right. Next, we have immune and oncology basics. The vaccines live versus inactive. So let's talk a little bit about our different types of blood cells. We have what is the immune system, right? It's the body's defense system. So its job is to fight infections, destroy abnormal cells, protect the body from the disease. So your immune system is your body's army. White blood cells are if you have it high, there's infection. If you have it low, again, increased risk of infection. Like that neutropenia. Neutrophils fight the bacteria, so they're the first responders. Lymphocytes fight viruses, right? They make antibodies. Monocytes clean up dead cells. So think of monocytes, they're the cleanup crew. Eosinophils fight parasites, increase with allergies. Basophils, you have your basophils that release histamines. They cause allergic reactions. Neutropenia. So low neutrophils patients have higher risk of bacterial and fungal infections. So nursing care is you want to wash your hands, avoid sick people, no raw meat or raw seafood, monitor temperature. They don't want to be around any Cats, you have like the garden, no flowers. So we want to make, because that could higher the risk. Um, and what is cancer? Cancer is the growth of abnormal cells. Remember, we went over this. They grow uncontrollably. Uncontrollably. You don't want to ignore any normal growth says signals. They can spread in the other parts. Remember, any the origin of the cancer, and then it mets to different places, metastasizes. So cancer cells don't know when to stop growing, right? So we have benign versus malignant. You have benign does not spread, usually grows slowly. Malignant is cancerous, invades nearby tissue, and can metastasize. With chemotherapy, it kills rapidly dividing cells. Common side effects: bone marrow suppression leads to low white blood cell count, which is infection, low RBCs, anemia, and low platelets, bleeding. You could get hair loss. There's nausea, vomiting, mouth sores, also known as mucositis. You want to teach the patient to use soft toothbrush, good oral hygiene, avoid spicy or acidic foods if painful. They could also get tumor lysis syndrome, when many cancers break apart quickly after treatment. This releases substance into the bloodstream that can overwhelm the body, so you have possible complications of high potassium, high uric acid, high phosphate, low calcium, acute kidney injury. So if they're having tumor lysis syndrome, you want to make sure that they have IV fluids, they're monitoring their labs, medications such as alpurinol. Infection prevention during chemotherapy, you want to teach them to wash their hands, avoid crowds, avoid sick people, cook meat thoroughly, as we talked about earlier. We also have our live vaccines versus inactive. Live vaccines is the weakened germ, inactive vaccines, dead germ or piece of the germ. The live vaccines, attenuated vaccines, they contain a weakened version of the virus. The weak germ can still replicate a little, which creates strong, long-lasting immune responses. Um, with live, you want to think of live, but like weak. Um, examples are like MMR, varicella, rotavirus, yellow fever. So the injectable flu shot is not live, but there is that egg allergy with the flu shot that you want to look out for. Advantages include strong immune response, long-lasting immunity. Who should not receive live vaccines, right? This is going to be big for your test. Somebody with HIV, severe immunosuppression, chemotherapy, organ transplant, and high dose steroids. And pregnant females generally avoid live vaccines during pregnancy, the risk to fetus. Possible side effects: mild fever, mild rash, soreness at the injection site. You also have inactivated vaccines, which contains dead organisms, pieces of the organism, recombinant proteins. They cannot cause disease, but because they do not replicate. Think of dead germs can't multiply. Examples include injectable influenza vaccine, Hep A, Hep B, you have the rabies, you have polio, Tdap, HPV, COVID. So some advantages: pregnant patients, many but not all can have these vaccines. Immunocompromised patients, The other the disadvantages with this would be like the booster doses, multiple doses. So you want to just look at the differences between them. So with live, again, living, leave it out if immunity is low. Inactivated, dead germs don't spread. Live vaccines are generally contraindicated in immunocompromised patients and during pregnancy. Inactivated vaccines cannot cause disease because they do not contain the living organism. Live vaccine usually produce stronger, longer lasting immunity. Next, we have genitourinary, the bladder, prostate, and ED. So with this, you have your different types of medications. Your genitourinary system includes kidneys, bladder, ureters, urethra, prostate, reproductive organs. Um, this helps with overactive bladder, benign prostate hyperplasia, erectile dysfunction. So when you have overactive bladder, the bladder contracts too often, which causes urinary urgency, frequent urination, nocturia, and urge incontinence. So you want to think of um, overactive as the bladder won't wait, right? You can give them anticholinergics such as oxybutynin, which is a diazepam. Um, they work by relaxing the bladder muscle so it doesn't squeeze too often. So you want to remember the side effects. If it's an anticholinergic, you can't see, can't pee, can't spit, can't poop. So you have your dry mouth, blurred vision, constipation, urinary retention. So you want to teach the patient to sip water, chew sugar-free gum for dry mouth, increase fluids and fiber to help prevent constipation. You want to use caution in older adults because anticholinergics can increase confusion and fall risk because everything's kind of slowing down, taken away. I'm so sorry. Cholinergic, actually, it's getting up, like tachycardia, things like that. So with BPH, the prostate enlarges and squeezes the urethra. So symptoms include weak urine stream, hesitancy, difficulty starting urination, frequent urination, nocturia. So you could think of like big prostate equals to blocked plumbing. That's a way to remember that. So we have alpha-1 blockers, which is like tamsulosin, that could be given, which relax the smooth muscle in the prostate and bladder neck, and that improves the urine flow. Some side effects like orthostatic hypotension is major. They may feel dizzy, faint, and fall right. You want to rise slowly, sit on the side of the bed before standing. We have our 5-alpha reductase inhibitors such as finasteride, Proscar, which shrinks the prostate over time by lowering levels of dihydrotestosterone. So you want to teach the patient. It may take months to see improvement. Then erectile dysfunction. We have sildenafil, which is Viagra. It works by increasing blood flow to the penis to help achieve and maintain an erection in response to sexual stimulation. So you want to remember, again, the biggest thing, it keeps coming up, nitrates, and that cannot be together because of the severe hypotension. Okay, for oxybutynin, Oxy dries everything from anticholinergic effects, dry mouth, dry eyes, constipation. Tamsulosin, you have take time standing because of the orthostatic hypotension. Finasteride, finally, the prostate gets smaller, so works slowly. We have our special populations. We have pediatric weight-based dosing, right? Immature liver, kidneys, altered metabolism, excretion. No aspirin for the kiddos. Geriatric polypharmacy, drug interactions, start low, go slow. The reduced kidney and liver function because the accumulation and toxicity can happen. Beer's criteria avoid strong anticholinergics and benzodiazepines. With pregnancy and lactation, avoid teratogens. I'm sorry, guys. Like if warfarin can't be given, ACE and ARB statins, methotrexate. Category replaced by risk summary labeling, folic acid preconception, assess for breastfeeding transfer. So you want to look at all of those things and let them know to look at the side effects. And again, the doctors will prescribe depending on the patient population, right? Like what is the special consideration? Renal and hepatic impairment, again, if somebody's on dialysis, certain medications need to be given in lower doses rather than higher doses or their normal doses. That affects everything. All right, guys, we're almost there. I'm sorry, at the end it gets a little like jumbled up. There's just so many slides to go over. So just, you have a few more days before the HESI. Please go ahead and make sure to look out for any information that you have not already known. Rest, we have herbal supplements. Like I said in the beginning, we want to make sure that we talk about supplements with the patients to make sure that they know to report those, right? There are some common supplements such as ginkgo, ginseng, ginger, St. John's wort, salt palmetto, valerian, kava, feverfew. It's all these different things that the patient can use. So we want to look out for any contraindications and interactions with other medications. So always ask patient if they take herbs, vitamins, or supplements. Like I said, the first one is garlic, and it's used for cholesterol and heart health. It's a natural blood thinner, so again, increased blood risk with warfarin, aspirin, and Plavix. Ginkgo biloba is for memory, circulation, brain blood flow. Again, it increases the bleeding risk. You have ginseng for energy and fatigue. It's the natural caffeine, but it can increase blood pressure, right? Because caffeine constricts the blood vessels, and affects blood sugar, and again, bleeding risk. We have St. John wort for mild depression. It's a natural antidepressant, decreases effectiveness of many medications, birth control, warfarin, HIV meds. So St. John wort really needs to be monitored. Valerian, used for sleep and anxiety. It's a natural sleeping pill. But major concern includes drowsiness, addictive to sedatives and alcohol. Kava could be used for anxiety. It's the calming herb. Liver toxicity, avoid alcohol and SNS antidepressants. Saw palmetto for enlarged prostate. So a lot of the elderly males may have this medication prescribed to them for the BPH. Cranberry helps prevent UTIs, keeps bacteria from sticking, but it may increase warfarin effects of the bleeding risk. Feverfew migraine prevention, so fewer headaches, but it's the bleeding risk. Ginger nausea, bleeding risk at high doses. So a lot of these thin the blood. Turmeric, we have inflammation, so it's a natural anti-inflammatory, but it still has bleeding risk, may lower blood sugars. So the big four we want to know though that are tested most often are garlic, ginkgo, ginseng, and St. John's wort. So with garlic, the bleeding, ginkgo, bleeding, ginseng, blood sugar, and BP and bleeding. St. John wort's drug interactions. St. John wort's induces an enzyme that reduces and interacts with drugs and doesn't let it absorb. Also, St. John wort's interacts with contraceptive pills. So some ways to remember the 4 G's and St. John's. Garlic is for the heart, but increases bleeding. Ginkgo is for memory, but want to look out for the bleeding. Ginseng for energy and blood sugar changes. Ginger, nausea and bleeding. St. John's wort, depression, but it decreases the effectiveness of many medications. So this here is just a quick toolkit. It's probably is within that medication comprehensive guide that I've given you guys. So go ahead and look at that again. Look at this PowerPoint. It has a lot of information. So if you know this, I'm sure you guys will do great on the pharmacology HESI. So please go ahead and look at this. Let me know if you have any questions, or you can let Miss Gina know if you have any questions, and she can let me know. But thank you guys for listening to this, and good luck for the exam.